I feel that a lot of discussion is always being dealt between the clinicians, researchers, doctors, but actually on the ground, allied healthcare professionals play a huge role in our patient's journey. And so we do want to hear from your perspective and what you would like to see, or your inquisitive mind in terms of how we can push forward the boundaries for our patient journey. Again, thank you both. So if there are any questions, please just put your hands up, and then we can address those questions as they come along. So in the meantime, I feel that we come from different perspectives for today's discussion, pivoting from sort of lung cancer to MRD. So if I can just marry those two together, Prof. Leong, in terms of lung cancer, because I do know, so MRD, its role is more researched and more pronounced in the colorectal cancer sphere. What is your take on MRD in the lung cancer, and can we marry it together with maybe low-dose CT scan that Prof. Anand was mentioning in terms of increasing our detection rate or screening?
Yeah, I think when it comes to technology point of view is that the technology will offer different type of options. So like what Dr. Anand, Prof. Anand mentioned is that it's multimodal. So whatever test or whatever screen is that, well, I believe is that the best screen is always the one that people will take it, right? Of course, combining the MRD with the low-dose CT scan would be one good approach to look at, because the MRD is a simple blood test, which is not so invasive, and you can do it in the GP office, basically, right? You are going to the primary care, you can actually do your MRD test, collect the blood in the GP office, you know, in the rural area, and then the blood sent to a central lab to actually run the test. So in a way, you decentralize it. Whereas low-dose CT is accessibility. So you only have probably certain well-established hospital would have it. So then it's more centralized. So when you combine these both, right, it doesn't replace each other. I always emphasize is that it shouldn't replace each other. It should synergize it, right? Similar, okay, if let's say MRD have detected something, yes, we will then refer to, you know, like low-dose CT. Or if low-dose CT detected something, then yes, it can be MRD to test for secondary mutations. So if vice versa, it's not one arrow, it's both way. Yeah.
Can I just comment on that? So I'm a little bit uncomfortable at the moment for ctDNA or biomarkers to be used, certainly in isolation, or to, come before some form of imaging. The reason being, we can have a situation where, as clinicians, hospital clinicians, where the patient has a ctDNA blood test done, and then they come to the clinic and it's reported as positive. And then you do the necessary work on the CT and PET, and there's no visible disease. So then what we have done is increase the patient anxiety. The natural question the patient will ask me, or a clinician in the clinic, is, right, doc, what's the next step? Can we biopsy, can you operate, can you irradiate it? And there's no visible disease. So I do believe, though, that molecular detection is going to be superior to imaging, and I think it will become part of the course. But at the present time, I'm not entirely sure whether it's to be used as a screening tool. That is the dream and the hope. And I agree with you, Prof. Leong, that it should be married with imaging. Where I see the role for ctDNA certainly is, and we do have evidence, right, even from Dr. Nina, from Checkmate 816, AGN, the lung cancer trials, that patients who get pre-surgery chemoimmunotherapy, 3 or 4 cycles, we call it neoadjuvant, and then they are found to be ctDNA negative from the blood test. That means there's no residual tumor in the body or in the blood, MRD negative, that who go on to have surgery, and of course achieve that PCR, that they actually have the best outcomes. And conversely, those who remain ctDNA positive pre-surgery after the neoadjuvant chemo, they have a worse prognosis. So I see the value at the moment for the ctDNA, the biomarkers, if we are brave enough, and this is more an oncologist's position, if you get a PCR, your ctDNA negative, no visible disease, can we perhaps de-escalate the treatment, the adjuvant treatment, spare the patient that added cost and toxicity, but keep them under very, very close surveillance with imaging and serial ctDNA measurements. Also, obviously, we like to use it as a monitoring tool, isn't it? Post-surgery or post-treatment. I do hope, of course, it will become good enough for screening. So right now, how I see it being used for the screening diagnostic bit is someone has imaging that is still the gold standard, which is LDCT. We hope AI-enabled chest X-rays will be, pretty useful as well. We still need more data for that. And then if someone has an equivocal finding on a CT scan or an AI-enabled chest X-ray, adding on a biomarker or maybe a ctDNA will guide the threshold whether we need, personalize the surveillance scan interval or the need to get a biopsy or even go for surgery. So that's kind of where I think the potential is.
Just add one more point is that I think whatever the approach is, it is always important to emphasize is that the awareness we need to create is that so that this test need to be prescribed by the healthcare professional. Please don't go elsewhere or you see on the Facebook and then you go for screening that, because your healthcare professional would be critical because they know what is needed to be done, what is a test that is best for you. So this whatever ctDNA, all this should be prescribed. Yeah.
Thanks, Prof. Leong. I completely agree with that, because I do think that products, technology is becoming more marketable and they're becoming more at the forefront. So a lot more sort of public awareness on that. So we have one question from the audience.
Hi, good morning, Prof. Thank you very much for the informative talk. I'm Luping from Institute for Medical Research, Ministry of Health. So as a scientist or researcher coming from a government background, I would want to emphasize that we need evidence of not only diagnostic accuracy, but also clinical utility and also cost effectiveness. So I would plead that when you launch opportunistic screening or subsidized screening program, please consider the element of research. Take liquid biopsy so that potential biomarkers can be evaluated and the evidence of clinical utility, cost effectiveness can be documented, so that we can ask funding from government to subsidize the screening program and it can become more sustainable in the future.
Thank you for the comment. I mean, definitely, maybe I think I will get Prof. Anand to comment a little bit on that, coming from LCNM and sort of screening.
Yeah, I completely agree and endorse what you're saying. At the end of the day, we all aspire to practice evidence-based medicine as much as we can. And of course, then we have to take the evidence and the data and then practice real-world clinical practice. So, it's an imperfect science, but most of what we do should be evidence-based. It should be driven by science. A lot of the trials and evidence comes from, global trials, phase 2, phase 3 trials. A lot of it conducted outside here. There are nuances. Our population might be different in terms of the demographics, in terms of the tumor biology, and then we have to hold the real-world issues. At the end of the day, I'll see a patient in the clinic, and they may be averse to chemotherapy, or they may be too frail, or there could be even non-medical things like the financial toxicity, affordability. So we work as a team. But the point you're making is yes, I think it's a great opportunity if we embark on any screening to try, and we have done this, LCNM has done on a small scale, a little bit of ctDNA measurements, or even using biomarkers like the CEA. But I'm not sure yet whether it's ready for prime time yet in terms of the screening element. But I see the value, as I said, in a confirmed or suspected case to use it to personalize the next step. But you're right, we need to collect data, whether it's biomarkers or tumor markers, so that it can inform, how we refine the screening and the risk stratification.
And also in terms of screening strategy, I would like to plead everyone in this room to think outside of the box. There's no longer just one standard screening protocol for one population, but as we move towards precision medicine and now precision in targeted screening, think about plan A, B, C. What if we cannot employ the perfect screening strategy in remote areas? Maybe then we would have options of non-invasive biomarkers that may compromise a bit of the accuracy, but it still work, and the clinical utility is still acceptable.
Absolutely. And on that last point, one of the exciting things for me, the potential for a chest X-ray, an AI-enabled chest X-ray, in my own hospital, which is down the road. Apparently, it's about 60 or 70 ringgit. Okay, so it's not cheap, but it's clearly infinitely cheaper than a low-dose CT scan, which in the private setting may be 500 to 800 ringgit. So, and you know, it is this can be deployed remotely. We do not need, for example, I'm talking about imaging rather than the molecular testing. So you can go to a rural population, you can go to a remote location, and you can go, you know, in the back of a truck with a scanner, not even a CT scanner, just a simple chest X-ray with AI technology. We can have junior doctors there, for example. So we do not require highly trained radiologists on site. So, but I think the future will lie in, as you say, a combination of imaging and blood, you know, molecular profiling, whether it's a biomarker, whether it's ctDNA. Of course, there's a bit of a turnaround time with that. The imaging can be done immediately.
May I know what is the price of a low-dose CT?
So I think it varies, but anywhere from, say, about 400 to about 800 ringgit, thereabouts. Yeah, I think it's more or less the range in most private hospitals. In government hospitals, it's free, but the problem is the government hospitals are already overwhelmed and burdened with confirmed cases that screening is not a priority, and you can see why.
So maybe in between AI chest X-ray and low-dose CT, there could be a biomarker.
Certainly. I mean, the other area of interest, I think, is, you see, all the evidence for screening, LDCT screening for lung cancer, quite rightly still focuses on people with a tobacco history, current or former smokers. And what I said in my talk is, we are seeing an increasing number of cases of lung cancer in the non-smoker, the never smoker, and majority being women, and also those of Chinese ethnicity overrepresented. More than half the patients I operate on for lung cancer are non-smoking Chinese females. Now, if we are rigid in just applying the Western data from NLSD, Nelson, we will fail to address this unmet need. So we need to capture lung cancer earlier in the high-risk non-smoker. Very hard to quantify secondhand smoke exposure, very hard to quantify air pollution. If I ask any of you what's your secondhand smoke exposure is, none of us know. But family history is something we can nail down. All of us will know if we have a first-degree relative, a sibling, a parent, uncle, auntie with lung cancer. So there's something, and there's data from Taiwan, from the Talent trial, which showed that, you know, the more first-degree relatives you have with lung cancer, the higher your risk. This is for the non-smoker and never smoker. So that is the group that I think we could invite to come forward even to do with the AI chest X-ray, you know, because it's a much lower radiation dose. It is much more palatable, much more affordable, widely available, and it's less daunting, less frightening for the average man or woman in the street than to come for an LDCT. And you can just, you know, you can do it anywhere in any primary care clinic. Yeah.
Thank you. I feel that, and I really want to invite more opinions from the floor. I feel that we are clearly in this scientific meeting, we are focusing on data, which is rightly so, and evidence-based. But I'm very interested in the data that you showed from the local population that you did during sort of the pandemic time in terms of AI-based chest X-ray and how there is, you know, detection of IPN. But hey, they're not coming up afterwards. They're like, okay, I've got IPN, but I'm not coming for the LDCT. There is a huge emotional, psychological aspect to our local population that we are not addressing. And I think if there is a challenge, that is the barrier. So I see a lot of patients with breast cancer, and we have the same thing. We can push for earlier detection, but there is still some stigma around that. And so, you know, I think it's not going to be an easy answer, but maybe our focus need to be more on that. What do you think about that, Prof. Anand?
Yeah, so that's a great observation, and I agree. I mean, what we learned the hard way when we did this community-based screening with the Qualitas group of GP clinics, you know, we thought, hey, we've got AI chest X-rays, we made it free, and it was around the pandemic, so, you know, or thereabouts, and one of the ways people were being followed up was with a phone call at SNS. Unfortunately, in Malaysia, there are a lot of scams, and people weren't picking up the call as well. So as we moved along that journey, it was over 2 years, we kept learning, and then we thought, right, we initially had a number of hospitals where if patients, a number of clinics where they could get the AI X-ray, and then if it was positive, go on to have LDCT in government and private hospitals. But sometimes, you know, it's like going to the restaurant. When you have a lot of choice, you can't decide. So we distilled down, and then we narrowed to just 3 hospitals. Even then it was difficult. Then we introduced, from Sunway University, we introduced a navigator, someone whose task was to gently follow up on those individuals who had an abnormal X-ray, and we made it free. So the X-ray was free, the LDCT is free. Because we know in Malaysia we all love things that are free. That's human nature, jokes aside. Even with all of that, the uptake is very, very low. So I don't know what, you know, traditionally you focus on men and smokers. I think women with breast cancer, women have more health-seeking behavior. Probably men are more averse to follow-ups and checkups. But I think one of the things I have learned in that process is we need to do it almost on the same day. When you give time, you do your X-ray on Monday, and then you give them an appointment to come for a follow-up CT scan a week later, 5 days, there's an attrition rate. People just don't follow up. I'm too busy, or I'm out of town. It's a fear as well, even when we made it free, even when we had a navigator. So we were able to demonstrate that out of 16,000 screenings, and this was in a way not targeted screenings, just whoever went to the GP, the GP decided, he or she decided that that person warranted an X-ray, they had it. 2 to 3 out of every 100 would have an abnormality. As I said, it's called an IP, an indeterminate pulmonary nodule. Obviously, the vast majority of those won't be a lung cancer. And I remember